Hello everyone and welcome today to the latest ECIST podcast on inclusion health. My name is Elaine Goodwin. One of my roles within ECIST is as inclusion health lead. I'm a nurse by background and I've worked in a range of inclusion health services over the last 25 years actually in the Leeds and West Yorkshire areas. And most recently, my last role, I was national lead for homeless and inclusion health at NHS England. So I'm delighted today to have Sam Dorney-Smith with me. We're going to have a conversation around inclusion health, homelessness and safeguarding. So Sam, do you want to introduce yourself?
Hi everybody, my name's Sam. So actually I was originally an A&E nurse, but for over 20 years now I've been working in homeless and inclusion health. My current job is as nursing fellow for the Pathway charity, and the Pathway charity sets up and supports homeless and inclusion health teams in hospital. What we're aiming to do is maximise the benefit of the admission and deliver safe and effective discharges. But I also have a number of other roles in homeless and inclusion health. So, for example, very recently I spent 2 years, 1 day a week, delivering street outreach in the City of London to people experiencing rough sleeping.
Brilliant, thanks Sam. And interestingly, my nursing journey started in ED department as well in Leeds, so we've had a similar path in our nursing career, haven't we? So today we want to focus on people who are at risk of homelessness and particularly looking at safeguarding and looking at thinking within emergency kind of context, particularly within emergency departments, etc. So just wondered what your views are in relation to this sort of context. So safeguarding homelessness and how we can support it.
I mean, it could be very difficult to safeguard people experiencing homelessness, and we know that because safeguarding adult reviews after death, of which there are many, unfortunately, involve people experiencing homelessness, tell us that there are multiple challenges, in picking up the red flags. I think one of the things is that when people come to A&E, they might come because their foot is sore and they can no longer walk, and they might talk to you about that, and then the fact they need a sandwich and the fact that they're withdrawing. They probably won't tell you about their liver disease or the fact that their HIV is untreated or whatever, because that's not their priority now. And often these people find it very difficult to articulate their distress. So, there's mental health, psychological trauma, language, literacy, all sorts of other priorities going on, which means it sometimes can be very difficult for them to articulate what their real concerns are. So often people find it very difficult to wait and engage with care, and as a result, people with what can be really quite significant safeguarding needs can end up leaving departments with their needs not met. And specifically, that can often be safeguarding needs around self-neglect. And I suppose one of the things I would say, which is so important, is to recognise your unconscious bias, because it's really easy to think that these are unwise choices or that this is a lifestyle choice. But in our specialism, we would say this is, for people, for example, that have an addiction, this is a chronic disease. It's a chronic disease with compulsion, and somebody who needs to inject 3 times a day, this isn't a lifestyle choice. This is somebody who is in the grips of a very serious chronic condition, who is going to find it very difficult to manage their life, and really probably is in need of safeguarding and will probably want your help as well.
Yeah. So and the points around the barriers that people face and that unconscious bias are so significant, aren't they? Because it's certainly I know the Less film that we'll put the links in after the podcast today, for me was really powerful. It talks about for people who have had experience of homelessness and a lot of the barriers that they faced, and some of those felt quite shocking, but actually I think it's really powerful to watch how I think all of them experienced unconscious bias from healthcare professionals, often experience probably unintentional barriers within interactions in ED departments or elsewhere in the healthcare journey. And yeah, so for me, those barriers are really important that we understand and kind of be mindful of. Okay,
Yeah,
so sorry, carry on.
that's all right. Because of that, people are often embarrassed and fearful before they come, so that they're really sort of hardwired to to see anything as possibly threatening. But I mean, a classic thing on unconscious bias, for example, is pain. So it's very common for people, for example, who misuse drugs to perhaps not have their pain needs kind of listened to, and if people are expecting that, of course, they're much more likely to disengage quickly. So it's really important to think about these things when you're delivering care to people.
Okay, great. So you've been involved in developing a new ED e-learning for staff working in emergency departments, and I just wondered if you could share with us some of the key areas that training covers and why, and any sort of top tips that you've got really.
So first of all, it will give you a sort of a bit of a background to the health emergency that sits behind people experiencing homelessness. For those that don't know, the Office of National Statistics produces statistics on deaths of people experiencing homelessness. That's mostly people who are rough sleeping, but the average age of death for that group is 46 for men and 43 for women, which is, really shocking. So it will give you that context. Then it talks about all the reasons why people self-discharge from hospital when they come, because one of the things that is true is that people experiencing homelessness self-discharge at a much, much higher rate than the general population. We know that. In the general population, it can be around 5% from A&E. In our population, it can be 20-25%. And it's all of those things that we just talked about, fear and embarrassment. The e-learning covers all of the different ways we can manage withdrawal, to pay attention to pain, but also to kind of tune into things like, they may well be worried about their dog, a significant other, their property. There'll be lots of potential concerns that we wouldn't necessarily tap into. So first it talks about self-discharge. Then it talks about self-neglect. And really it starts off with the premise that, it's really important not to conflate mental capacity and self-neglect. If you think about somebody with domestic violence, for example, who's a domestic violence sufferer, they're a domestic violence sufferer whether or not they've got capacity. And obviously our responses to that and how we might help them will change dependent on doing a capacity assessment around their decisions. But the identification of the domestic violence is an objective thing. And similarly, if you've got somebody who's self-neglecting to the point where they're putting their life at risk every day, that is self-neglect. See it for what it is, respond to it. And the e-learning also helps you, because I know that many people in A&E will have referred to safeguarding, and maybe that hasn't resulted in any response. But in the e-learning, it will tell you, what to say and the kind of things that you're trying to achieve from it and how to follow up and that sort of thing. It then talks about mental capacity and how difficult it is to do a mental capacity assessment, sometimes with people experiencing homelessness. It's a common myth that anybody can do a capacity assessment, but actually we are talking about people with multiple complex needs who've got multiple communication difficulties. And when we're thinking about the evidence that you need to show that someone has capacity, I can tell you myself from doing multiple capacity assessments, for example, on the street, that it's not a 5-minute job. Often to unpick these things, people, they're suspicious often. They just don't want to engage with the assessment. They don't understand it. It takes a while to build a relationship, and then to ask all the right questions that draw out the information that you need. It talks about the presumption of capacity and, how that gets misused. So, we know that presumption of capacity. So, for example, if you have an older person with dementia, we shouldn't presume that they can't make a decision about what to eat or what to wear. But it doesn't mean that if someone's leaving the department with their leg falling off and you haven't been able to communicate with them, that we should presume they've got capacity. The presumption of capacity is where to start and not where to end. So the e-learning goes through all of that and all the case law on that. And it will also give lots of tips on how to do a mental capacity assessment or make it easier. So, for example, you can probably tell I'm a devil for this. Sentences way too long, putting too many things together. And Lee Andrews, who's a speech and language therapist, has inputted a lot into the e-learning to show you how to keep those sentences short, keep the sentences direct, to check in, to check that you've got your understanding right. And she has taught me a huge amount about how to do these things effectively, and that's really drawn out well in the e-learning. And then last of all, there's a really important section which deals with all of the other stuff that you might do, from making sure that people's housing status is being documented in your A&E system, to getting together resources, resource booklets so that people know where the local support in the community is, to running awareness raising sessions in your department, and films like the Less film that you just talked about and other films that we know are really good are there so that you can use them. There are safe discharge checklists to help people, even the most junior staff, think about safeguarding and mental capacity when they leave the department. So there's a whole host of resources there. The lovely Shona Duffy at the Gloucester Royal Infirmary and her wonderful project is profiled within it, but also work from other areas. So, for example, Leeds and Bournemouth. So it's a really good resource, and hopefully anybody that does it will leave with a much better sense of how they can support people experiencing homelessness when they come to A&E.
Thank you. And it's brilliant as well to hear that there's lots of examples within there around kind of top tips and ways in which we can take action in what can often feel like a really impossible situation for people, can't it? And I'm just wondering around the kind of trauma lens as well. And as we know, most people experiencing homelessness will have experienced some form of trauma in their life, whether they're a vulnerable migrant, whether they're whatever their background has been or continues to be their reality. I suppose for some, there's the kind of aspects about the language we use as well, isn't there, around that, what's happened to you rather than what's wrong with you, what matters to you rather than assuming we know what's important for people, etc., etc. And I just wondered if there's anything around that kind of how we work with people who've experienced such levels of trauma that you feel is important to kind of consider as well.
I mean, the points that you made there were really excellent. We know that the level of adverse childhood experiences in our population is absolutely huge. And as I said, just, on account of that, people often come into departments expecting it all to go wrong. They're already on high alert. And I think we all, when you work in A&E, it's quite exciting, the sounds, the lights, all, people moving all of the time. But for a lot of our clients, it in itself can be really traumatizing. I think it's really important just to make sure that people can have their own space where I mean, I know it's very difficult, but I mean, lots of people just feel that people are looking at them, you know, they feel that they're being judged. So just simply being given their own space, you know, if somebody is asking for a cup of tea or a sandwich or whatever, it's not unreasonable. So trying to meet their needs, you know, being respectful around and trying to negotiate around if someone, you know, needs a cigarette or whatever, or, you know, they're telling you that they're withdrawing. All of these things are really, really important. But I think from the point of view of trauma, you just always got to try and put yourself in their position, you know, try and empathize, try and build a relationship. Just imagine that it's your brother or sister first. And it's really, really difficult to do. It's really, really difficult to do. And I admire anybody at the moment who is working in A&E. You all have my, you know, massive admiration. But just to say, you guys, you are the front door for a lot of our clients. You know, you will be the first. You know, the reason that they're coming to you is because they don't have access to other health services, and you know, if you can be kind, if you can build that relationship, you know, and make health feel like someone's friend, you can make a massive difference in someone's life.
And I know in the last film, if I don't know if people do get a chance to watch it, please do. But if you don't, there's a guy called Jeff who's fab. Met Jeff a number of times, and he talks about his experience in the film of very negative experience in a department where he was treated really badly because it was perceived he smelled. But then he also talks, I think it's Jeff anyway, that talks about how actually the sliding door moment where there was one practitioner who listened, who asked him about what mattered to him and showed him kind of compassion, and that was a turning moment for him in his journey. And actually he talks about that in the film, about how that was kind of catalyst to him coming out of homelessness. So I think for me as well, when we think about that, so part of this series is around inclusion health, looking at the different aspects, including homelessness, but about that call to action, what we can be doing as health practitioners, but also around some of, because, you know, I know there's lots of people out there who do want to take action but just don't know how to. But some of it can be really simple steps like, hello, my name is, how can I help you today? So I suppose just thinking about those top tips, and you've covered a range of them already. So I'm thinking from a frontline practitioner perspective over to a strategic leader perspective. What do you think? You've talked about the ED toolkit, which is a fab practical toolkit. Within there, it talks about having named leads within each department who are the leads for homelessness, because obviously we can't expect everybody to be kind of knowledgeable specialists in every you know, single issue that may present through the ED door. Are there other sort of top tips, toolkits you can think of? Obviously there's ED learning that you've shared there.
So there is so many things. I mean, if you could go to the All Our Health website, there's loads of stuff on inclusion health from all sorts of different perspectives, from a frontline and strategic perspective. If you go onto e-learning for healthcare and put in the word homeless, there are a number of modules that come up, including the duty to refer, and I'll come back to that. The Fair Health website also has some really excellent resources, not just this e-learning, but lots of others, and a Nemo. So there are a number of different platforms. Just returning to what you said at the beginning, when I was in A&E, I think people saw me as the homelessness nurse, and I was the person, you know, that sat in triage, and you know, those days you could do it. You know, everybody had their blanket and their cup of tea and their sandwich, and I'd chat to them and whatever. It never once occurred to me in A&E that I could do anything about their homelessness. I was kind and I was respectful, and And I meant well, but it never once occurred to me that I could do anything about it. It never once occurred to me to connect into a community nursing team or a specialist GP practice, and, you know, or contact housing. So just to say, you can make it. I know it's difficult, and I know there's capacity, but you can make a difference. And one of the key things that this, you know, all of this draws out is, you know, if someone's coming to your department regularly, particularly if they're self-discharging regularly, you know, do try and connect with other people, you know, try and connect with other services in the community. Do try and find out what you can do. The Homelessness Reduction Act, the duty to refer, applies to A&Es, but it was brought in for this reason, to, you know, take action, because actually the council may not know about this person, and you might be able to broker that relationship that will make the difference. Just to say, in terms of other resources, please do think about joining some of the specialist networks. So the Faculty for Homeless and Inclusion Health, run by Pathway, is free. The Homeless and Inclusion Health Programme Network from the Queen's Nursing Institute, also free. London Network of Nurses and Midwives Homelessness Group, and the NHS Futures platform has a homelessness group as well. All of these platforms will, you know, provide information about the latest evidence, training, all of these kind of things. But also, if you want to connect into other people who are trying to make a difference, that's the perfect way to do it, because there are lots of people out there that will be wanting to connect with you too.
I think it's remembering as well, isn't it, that you don't have to do all of this on your own as well. So there's something about the collective action of us all to have responsibility to understand the context, whether that be broadly or kind of quite specifically, knowing where to go if you're not sure. You know, have you got a homeless link within your department? If you haven't, why not raise a question with your line manager or with the department manager? Also, it's remembering, I suppose, from like a system perspective as well, understanding the context, understanding, you know, what services are there, what the gaps are. And it, for me, it's about that collective response, and not feeling like you've got to own this all on your own. And next time someone comes through that door, that you're expected to spend hours with them trying to support them. It's remembering often as well that it's the small, really small things that can make the difference. That the smile, the warmth, the care, the compassion, and not, So,
but I've seen again in it. So I just having a named person in A&E who, I mean, you'll have other named nurses or links in A&E, but someone who's just responsible for understanding who the day centres are, who the advice services are, who the street outreach services, who the specialist services, can make a massive difference. You know, and getting those people connected in, for example, to your high intensity users group, can make a huge difference to what you can achieve. And I can't tell you how much those community services will so appreciate the connections being made as well, because often they really find it difficult to, you know, if they're just in a situation of having to cold call the hospital, it's really hard to know who to get through to, whereas just having that one connection can make a huge difference, for example, to a street outreach team, because they want to let you know that they're sending someone in, they want to let you know the collateral information, they want to let you know their concerns, and it's so easy for information to get lost if it's just written on a scrappy piece of paper. So if you can do that, it will make a massive difference.
Brilliant. Thank you, Sam. Anything else before we go? We will put the links into resources, as we've discussed at the end of this. Some really brilliant toolkits, and as Sam's described, her e-learning and other sources of support. Particularly, you've just made reference to the high intensity users programme as well, which is really key. There's also nice guidance that's out, but we don't want to overwhelm everybody with lots of information, so we will put the links into that to the end. So any final comments from you, Sam, before we finish?
Yeah, I suppose the last thing I would just say is, you've probably got a sense of that from what I've said, is that you know, from what we know of people's health outcomes, in this group, these people are far more likely probably to die in the next month than probably anyone else you see. So when you see somebody who is experiencing rough sleeping, think about that as a red flag, and just think from what I've said about the difference that you can make. And if you can gauge someone in healthcare, if you watch those films, you can make a massive difference to someone's life, turn the life around, you know, and that's what you came into nursing or medicine for, ultimately. So this is your chance to really make a difference.
Thank you.